the entire PTV is considered one volume, and that's, to me, too large. The diameter will be greater than 2 centimeters. And so I always fractionate to 3 or 5 fractions, and I do it the same way. And if the targets are close, the PTVs still shouldn't merge unless they're within 1 millimeter of each other. We use SRS mask with surface guidance, so we have continuous intrafraction motion monitoring. I spent 3 years doing the majority of cases with fixed frame as well, and that is a very good option as well if you have somebody trained to put the frames on. Both are good options for immobilization. But if you're using a mask, it would be helpful to have intrafraction motion monitoring, meaning we get the cone beam with the mask on at the start of treatment, but there should be some way of seeing if the patient moved between the arcs. We use surface guidance. You can also use the onboard MV imager in a LINAC to do so. But if you don't use intrafraction monitoring, it may be better to use a frame.
Okay, now you can see my screen, right? Can you see my screen?
Yes. Yes,
okay.
Yes, we can see the screen.
Okay, so sorry that somehow my computer crashes, but okay. So I will basically give an introduction about SBRT, SRS, because this is our first lecture, and as Dr. Siddiqui mentioned, that brain is actually quite a challenging cases. Once you learn about the brain, radiosurgery, other disease side is not as challenging as brain. Okay, so but I will mainly focus on from physicist perspective to give this lecture. Okay, come on. Okay, I want to give actually the basic knowledge about radiosurgery. Actually, the history started in 1968. Nexel is actually a Swedish surgeon. He basically developed radiosurgery, and it's not actually a conventional sense. It's surgery because there's no incision. And basically, Nexel developed gamma knife at that time later on, and the difference SRS, SBRT, and are similar, actually, the same modality, but SRS is mainly focused on the cranial, and SBRT is for extracranial. For example, later on we'll talk about lung, liver, and pancreas. This is SBRTs. Yeah. So in terms of SBRT defined by American Society of Radiation Oncology, there's several components actually you have to pay attention. One, you have to use an imaging guided. I know for all these countries, low and middle income countries, they already started with IMRT. So imaging guidance, it is part of now workflow. As Dr. Siddiqui mentioned many times, you really need probably need advanced imaging modality, for example, MRI, spectral frame for brain. For lung or other disease, you may want to use PET to define your target. Then is high dose radiation therapy, and with less number of fractions. Usually is less than 5, does not exceed 5 fractions. So that means if dose is very high, so the safety and quality assurance is very, very important, right? You don't want messed up. And so also it's involved, sometimes the real-time motion management. It's not required, but it's highly recommended and give you more confidence, especially when you deliver, for example, a single fraction of 21 gray to a brain tumor, right? And for us, we use the surface imaging, but for like LMICs, when you start it, you probably don't want using one single fraction unless you have, for example, like a real-time motion monitoring or motion management. Okay, number 6 is like a robotic delivery. Cyber is mainly about CyberKnife. There's a lot of automation, even these days on the LINAC based. Okay, again, this is 3 terms: SRS, SRT, SBRT. Sometimes it's very confusing. SBRT, we talk about is high dose in-mass fractions for extracranial. SRS, SRT focus on radiosurgery of brain, and SRT basically is multiple fractions. SRS is one single fraction. Okay. For medical physicists, I highly recommend you read two actually guidelines from AAPM. One is AAPM TG 101, Task Group 101. The other one is more recently MPBG report 9.8. It talks about all details about physics implementation, QA, simulation, immobilization, and imaging. So if you cannot download, email me or Geneva, I can send you over, or I can share in some kind of share drive. Quite very useful. Yeah. For physician, I also, there's a lot of SBRT, SRS protocols. This is something you can also read, understand, as Dr. Satiq mentioned about the brain mass, and as all other disease side we're going to cover in the next few lectures. And however, for your reference, you can read these protocols. Okay, the SBRT workflow, because I'm a physicist, I'm trying to focus on, the safety and the quality. Actually, that's basically physicists play a very important role about, the implementation of like new technology. For, actually SBRT definitely is not new in the US. However, it is very new in low and middle income countries. I'm very proud that, the several sites I worked in the past, from 2D to 3D to IMRT, now you want to tackle SBRT and SRS in a very short time, in a few years. That's a lot of work, So I was thinking that hopefully this kind of remote training will give you some idea, how SBRT, SRS works. And hopefully, you will gain more experience when you're starting to treat your patient. So the overall SBRT workflow, it is actually not very different from a conventional, for example, IMRT or VMAT workflow, and from simulation and to delivery, right? So, however, there's a small, details you should pay attention. For example, the simulation, right? The tumor size is very small, right? You want to use a high resolution imaging, for example, like a slice thickness, right? So for us, for like a brain mass, brain surgery, CT simulation, we use 1 millimeter slice thickness, which is actually very different from, for example, like across the head and neck. We use like a 3 millimeter slice thickness, right? Then immobilization is very, very important. That is the key. And so you definitely want to actually, achieve like 1 millimeter or even less for brain, okay? For like lung, liver, you definitely need also 4D CT, which is also new to, if you want to treat SBRT. So the reason why when you define a target, right, you don't want to add a big margin. Therefore, 4D CT is needed, especially for body SBRT. The planning, actually, I will also cover that. The dose evaluation is also different. And here for SBRT or SRS is highly conformal plan. You will see that later on. And also dose is not homogeneous. Actually, inhomogeneity is better for many of brain mass. Then, as I mentioned, that for real-time monitoring, to be honest, it really depends on the size of the tumor. If you are treating like 2 or 3 cm, probably it's not required, but it's better to have because it gives you more confidence, right? Then the motion verification, for sure, you need a CBCT is required for every fraction. And also probably, if you have like a gating, that's even better, especially for lung. Then the delivery, yeah, it's a very high dose. Okay, this is mobilization. And so I just give one example for brain, right? So in the beginning, for like a radiosurgery, you use like a frame, especially if you know gamma knife, right? Now, these days, like LINAC-based, nobody's using frame and they use the frameless. It's kind of like a thermoplastic mask. However, it's not every mask can achieve, very high accurate immobilization. We use basically Q-fix. This is called encompass mask. I will mention that. You can see actually in this picture here, it's kind of like a face is open. Its reason for that is used for surface imaging. Surface imaging does require actually skin surface to monitor the motion. Okay, so this is a question for the team, especially for physicists. Are you ready for your SBRT and SRS? I know that you probably want to start it. This is a few questions you think about, right? Do you have equipment? I think the majority of the center you do is basically a linear accelerator, right? I think as far I know that almost every center you have a true beam, right? Then you need to consider about immobilization device, for example, like special mask or 4D CT, the imaging 4D CT, and do you access to MR scanner? I know in Uganda you don't have MR scanner in your department, but you can access from radiology. I think that will be okay. Then you learn about the planning and of course the treatment. CBCT is basically required for every fraction. For physicists, you need also commissioning your beam data. This is something I will also talk about in the data validation and also and QA, also about machine QA. Okay, so conventionally, actually, many centers still using the gamma knife. I mean, it's great technology. However, it's cobalt 60, and you can see it's about 200 beams from different angles. You can achieve a very conformal plan. However, probably it's not easily available in many low and middle income countries. Then the other one is like a robotic arm from CyberLife. This is also another machine, specially designed for radiosurgery. And you can see this one basically can catch up, can pick up the cone, different size of a cone. Or these days, the new machine has dynamic MLC, treat a very small target. However, today I'm mainly focused on the LINAC-based SRS and SBRT. I have checked that survey from all these 4 or 5 institutions. Looks like you are all like varying users. I would assume, I think Guatemala, you may have a housing. It's a little bit challenging, but it still can do SBRT. So the LINAC-based SBRT and variant actually like edge or true beam is very popular for radiosurgery, and they usually offer like 6 to 10 MV energy with high dose rate, 6 FFF. If you want to treat SBRT, I highly recommend using the FFF beam. I know Uganda and Mongolia, you have this machine with 6 to 10 FFF. The reason why is the dose is much higher because you are delivering a very high dose. So you want to deliver more efficient, right? For us, we use 6 FFF with the highest dose rate. Many of these machines actually use high definition MLC, but however, it's not really required. It's very useful when you treat very small tumors down to, for example, a few millimeters. I have seen many places using regular MLC and still can treat like above up 1 cm target. So I would probably assume that you will start in probably a lot larger, like 2 or 3 cm size of radiosurgery. Or you can use ICVI. It's kind of like a physical cone. When you treat like a trigeminal or very small 5 or 6 millimeters size. Cone probably the safe way. However, it does require the monitoring. That's the reason why this machine usually comes with surface imaging, a line RT or identify for patient positioning and monitoring. If you don't have it, use probably depending on the size of the target, right? If you treat about 3 cm size, patient move about 1 or 2 millimeters, it is still okay. But if you are treating like 7 or 8 millimeter size, right? The accuracy, if you cannot achieve sub-millimeter, it can be a question. Also, this is highly recommend using 6-degree couch. The reason why you set up, right? A pitch roll and can be also used for correction. It's for better setup. Okay. And for like a variant machine, you can also like KV, FV imaging trigger. So you can basically do actual delivery. You can also see the real-time KV imaging. Okay, the beam data acquisition, to be honest, there's really not much different except output factor measurement. So in terms of beam calibration, you don't have to do it again. you already commission your machine for your 3D or MRT. You follow either AAPM TG51 or IEA TRS 398. You already have PDD profiles in your TPS. And however, you do need to actually include the small field size. In our TPS, we measure down to 2 by 2, including 2 by 2 centimeter square PDD profiles, and including the output factor here, down to 2 by 2. Check your TPS. If you don't have 2 by 2, I think you should measure it and complete your beam data. That is the key. Okay. However, the output factor measurement for small field is very challenging. This is actually many papers has been published that, right? Especially down to small field size, like down to 2 by 2 or even 1 by 1. And we recently measured like 0.5 by 0.5. You can see the different detectors can give you the output factors up to like 10 or 12% difference. This is from different factors. Okay, if you normalize 4 by 4. So the output factor is very, very important factor, which determines how much dose will give to the patient. Yeah, if you commissioning, this actually happened. The New York Times reported several cases. Basically, several hospitals need basically overdose by 50% the patient for a large number of patients in several centers, including Florida and Missouri. It's because output factor measurement is a wrong detector. Okay, this is very, very important. So right now, I think Varian provide bone beam data in your Eclipse, but I don't know whether it's including 2 by 2. Probably have 3 by 3. If you want to SBRT, I would probably highly recommend to go to smaller field size than 3 by 3. Okay. If you have any question about that, you can reach out to me. I can basically double check your machine. The good thing for Varian machine is pretty much all the machines are matched, which means the TrueBeam at the Baylor College of Medicine in Houston or in WashU, Uganda, or Mongolia, they are all actually the same machine. In this way, you basically can benchmark each other, make sure your output factor is correct. Okay. So large field versus small field, the dosimetry are different. For large field, right? I give one example, 6x. It's quite flattened, right? And the jaw size is pretty much defined at 50% or 4 width at half maximum. However, for small field size, because the jaw size is so small, the penumbra scatter, actually the 50% does not represent really the collimator size. So which means if you use a large detector, you measure basically, it's kind of volume average in the top, which does not give you accurate results for the output. This is another example for detector size. Okay, when you scan the profile in the penumbra region, right? If you use a large detector, the volume average effect is quite big. So your penumbra is much larger than the real actually profile. But smaller detector, it is definitely required when you measure the profile PDD for small field size less than 3 by 3. Okay, and this is a recommendation for small field dosimetry when you're commissioning your SBRT. That's multiple. Usually the detector size should be less than 1/4 of field size. For example, if you are going to measure 2 by 2, right? The recommendation for detector should be less than 5 millimeter. Okay, so that's several detectors are using for small field dosimetry, including the diodes. Okay, usually the size is about 1 or 2 millimeter. Diameter detector is a little bit more expensive. It's also about 2 millimeter size maybe. And recently, the pulse scintillation detector is very, very useful. Does not require any correction factor when you measure output factor. So for small field dosimeter, this is itself can be 1 hour lecture. So I just cannot focus too much details. And this is something, if you are interested in that, you should look into that. And also, if you use an ion chamber, it's going to call a pinpoint ion chamber. So for field size, but does not apply something like below 1 cm. Okay. Then I highly recommend when you start to treat your patients, you perform an end-to-end test This is basically a phantom for a variant. You can also buy this kind of and test phantom from other vendors. I don't actually here to endorse any vendor. The end test, which will including basically the imaging, right? Your immobilization device. It's kind of like a dry run to mimic your workflow, right? You do imaging, make sure you're scanning with high resolution scan. You have robust immobilization, can achieve a millimeter accuracy, and then you import the data to TPS. Make sure you can also register your MR or PET or contour to the planning, and then you can also verify the delivery, and also you can insert your diode or detectors into this phantom. This is actually phantom that include the film and also including the TLD. So you can see, this basically mimic your workflow. You can use the film analysis. You can check the profile, compare with the TPS, right? And also you measure the dose with calculated dose. For this case, for example, 3%, which is acceptable. So this kind of end test is very useful when you actually implement your SBRT SRS program. Okay. This is also very important QA for like SBRT SRS machine QA. TG AAPM task group 101, you probably can find a similar report from IAEA. The Winston loss test is machine QA when you do the Winston loss test. Right now in our clinic, we do running every day. We have SBRT case, which means actually in this phantom is very easy. Just a small cube or any like phantom, small phantom, you have BB inside. Then you are going to basically deliver a small field, better defined by the MLC. Okay, rotate, different gantry angle, different couch angle, different column angle, get accurate images. The reason why we test that, you are testing basically the imaging ISO and the treatment ISO coincidence, and also the walk off a different gantry couch rotation, right? You definitely want to achieve a machine like less than 1 millimeter. The different gantry in the couch in the collimator angle. Okay. Okay. Immobilization mask. The mask. Yes. Any question? No. Okay. I will continue. So this is for in our center. I think most place either using Civico, using QFix. For us, we use QFix Encompass SRS fibroblast mask. You can find it on their website. This is basically it's only compatible with HyperArc. It's a special license for radiosurgery planning in Eclipse. If you don't have it, you still can make a plan. I will show you actually in a few minutes. Okay, so this is combined with the couch overlay. This is basically, it says it can achieve a sub-millimeter positioning accuracy. Okay, so in the next few minutes, when I talk about planning, but I cannot cover too much details. In the last lecture of this training section, we will have a designated 60 minutes to 9 minutes to give you detailed planning. Pick up 2 cases, for example, brain. For this case, is single fraction 21 gray. Dr. Siddiqui already mentioned that, right? You can treat one isocenter, but I want to give you one example with a simple case. Just using one isocenter. Okay, so usually the isocenter is in the center of target. Okay, and this one is a little bit on the left, so you can see my beam arrangement is pretty much on the left side. However, for the brain, SRS planning is usually required at least some non-coplanar beam, which means couch clips, right? To achieve high conformal, high those fall off. So by the way, for SBRT planning, SRS planning, so those conformality is very, very important, and also those fall off because you don't want to give a lot of those. Those. Okay. Maybe. Any question or Okay, so for this case, as I mentioned that for all our SBRT in our center we use 6FFF, highest dose rate 1400. Then we used VMAT, and usually for brain planning we used at least 4 half arcs and at least 2 long coplanar beam. The reason why that can achieve a better conformality, and usually collimator should be rotated up to 0. Okay, another small details, and you should pay attention about dose calculation grid. Usually for regular MRT plan, I believe your dose calculation grid is 2.5 millimeter, but for like SBRT, SRS would reduce dose calculation grid 1.25. Yes. Okay. So to avoid collision, and definitely your arc path should be avoid traveling to inferior of isocenters. For example, here is isocenter, right? Your arcs are all over there, and you can see the beam geometry here, right? It's quite important to pay attention about your beam geometry. I see here I use the 4 half arcs. You can see, right? So B1, you can see that the gantry angle is 179 to 0. It's like this way, right? When the couch is 0, right? Then the next step, you're going to rotate the couch to 45 degrees. Then you rotate it from 0 to 181. Actually, this way, 0 to 181. Yeah. So when you do delivery, you pay attention that your delivery efficiency, right? For example, your gantry angle from 179 to 0, couch is 0. Then the gantry angle from 0 to 180 is kind of, similar like a gantry is like a full rotation. However, before you rotate the gantry, you rotate the couch first. Okay, so like this way. So couch is 45, then 0 to 181, 180. That is actually avoid collision. Now the next one is you rotate the couch to 90, then you continue to rotate the gantry angle from 181 to 0. Yes. Now you rotate the couch to the other side, 315 here. Then you rotate the gantry. So to avoid collision when you deliver, you always rotate the couch, then rotate the gantry. That's very, very important. Number 1, to avoid collision. Number 2, for delivery efficiency. Okay. Optimization. In Eclipse, you have very important feature is about for SRS. It's called normal tissue objective. It's basically simplified the planning. For here, the normal tissue objective, you go to optimization, you can see that. Usually we select auto SRS NTO. I cannot explain the physical meaning in a short time because it's a little bit more complicated. So you set like a 100 or 120. Then objective, actually, to be honest, the objective for SRS planning is easier for regular MRT. It really depends on how many, organ risk over there. So for example, GT for this case is 21 gray, right? You want to cover 100% of volume by the prescription dose and give a little bit high priority, right? This is for the GTV. And this is pretty much manually type in objectives, optimization objective, right? For PTV, for this case, at 1 millimeter. By the way, for the margin, this is something question you probably should discuss. What margin should you use? It really depends, right? Some places highly confident in the US using 0 margin. For us, many cases using 1 millimeter margin. For your situation, for your center, you may want to actually in the beginning choose a larger margin. The reason why I don't know, how accurate immobilization, right? Your imaging registration, so far and so forth, right? Immobilization, that's very, very important. You may want to actually give a little bit margin, like 2 or 3 millimeter. I mean, depends on the size of the target. Okay, looks like I have some questions. Okay, I probably will have, okay, you guys to, Dr. Abadana to have 100 questions. Okay, so the PTV, you also, give, okay, you can see from 21 grade to 27 grade, it's a big jump, right? It's about 30% maybe, right? So this is one of the reasons that you can allow dose maximum can be like 20 or 30%. It's no problem. So for this case, you want to actually limit the highest dose to like 35% maybe, 27 gray. Then for PTV, you want actually 98% covered by 21 gray. This is based on objective you can put in the for PTV. Then to achieve, if you don't have a hyperarc license, you can basically draw a ring structure. For example, you can draw a 5 millimeter ring, right? You can also draw like additional ones, say based 1.5 millimeter ring here, R1, R2. You basically give a maximum dose objective. For example, 5 millimeter ring, you want actually limit dose, the maximum dose, 0%, get 21 gray. Then like 1.5 cm ring, you want to get 0% less than 50% of your prescription. That actually will make your isodose more conformal. This is based on some tricks. We can talk later on, but this is if you don't have hyperarc license, you basically need to achieve better conformality. You can use ring structures. Okay. Let's see. The plan evaluation, sorry, we're running out of time, but I will quickly go through that. The plan evaluation, as I see that dose inhomogeneity is okay. Actually, our doctors prefer that the hotspot above like 20, 30%. However, hotspot has to be within the PTV, GTV. You can see that the isodose line is so condensed here. It is because, we have to have dose fall off has to be fast. Okay, it's radio surgery. You don't want to give, dose to normal tissue, right? Conformality index is, Dr. Sadiq already mentioned that it's based on the volume of the prescription isodose line, which is 21 gray, divided by PTV volume. Usually, ideally is 1, right? It's totally completely conformal. But for us, usually should be between 1.0 to 1.2. If above 1.2, which means your plan is not conformal. There's another index called R50. R50 is basically the ratio of 50% of prescription isodose line to the PTV volume. Usually should be less than 4. Okay. Depends on the tumor size. For this case, I believe it's about 3.5 or even smaller. I don't remember. Okay. This is called R50. It's another index when you evaluate a plan. There's another parameter called a gradient measure. Is for this case like the distance between the equivalent radius of 100% prescription isodose over to 50%. Yeah. Sorry, I just muted. Please, if you have a question, please type in. Just okay. Okay, this is the last few slides. As I mentioned that, we have one case, 46 brain met. This case you can treat with whole brain, but we prefer actually treat, 46 brain mets. We use one isocenter, and we give one fraction 16 gray, and here is pretty much the standard the beam geometry. You have these 4 arc, right, from 180 to 181 to 170 line, for example, right? Then you have 3 standard couch kicks, this kind of geometry. Collimator, you can choose basically every arcs using different collimator angle. So I'm running out of time. Basically, it's objective for this case, again, normal tissue objective is very, very important. Thickness 120. And actually, economic planning is very, very straightforward, especially if you have hyperarcs. Take breaks in a few clinics. Few clinics, you can make a plan. Yeah. So this objective, right? For this case, you basically, for all the GTVs, 100% covered by the prescription dose. That's it for this plan. Okay. So the patient QA, I have a few slides. You need a high resolution detector array, to QA your plan. Because tumor size is so small. The regular, like 7 mm to 1 cm resolution does not work very well. It depends on the size of the tumor, right? This is one of the detector from Synuclear SR map check. Okay, the resolution actually, the detector area is about 5 mm, actually 0.5 mm, 0.5 mm. detector spacing is about 2.5 millimeter. However, the detector size is not very big. It's about 7 cm times 7 cm. Okay. This is I used at my previous institution. Then this is another one I'm using right now. It's called from PTW Optimus 4D, and this is also high resolution detector. For this case, for this detector, I like it because it's ion chamber. For SRS map check, it's diodes, a smaller size, but this one is using ionizing chamber, and also the detector size is 15 by 15. You can pretty much capture all the brain mass in one measurement, not like SRS map check. You have to QA every tumor. Okay, so this is one example. We have done that. You can see Octavis measurement, right? Using one capture, you can measure basically, all different tumor size and, one single ISO, very high passing rate, get, I think 100%. It's 2% 2 millimeter criteria for gamma. I think that's all my slides. We are running out of time, but at line 34, I know it's very late for some of your countries. And okay, now, are there any questions? Okay. SRS, SRT, okay, Dr. Abdallah already. Okay, ICVI, I really need to check Google, to be honest. It's kind of like a physical cone. Yes, let's see. Any other question? We'll continue actually, I guess, in about 2 weeks. ICVI. It's integrated corneal collimator verification in the index system. Okay. Yeah. It's basically a physical cone. How far does it differ using the hyperarc license versus normal tissue control range in regard to conform? Okay, that's a very good question, to be honest. If you use hyperarc, it does really not require a lot of experience about planning, okay, to achieve a conformal plan. If you don't have hyperarc, you still can achieve, okay, the similar plan conformality, but you need, create like optimization structure, for example, the ring structure, right, to achieve conformity, better conformity index. Yeah, it takes a little bit longer and additional skills, to make sure your beam arrangement, sorry, somehow my system has issues again. Okay, so the question is, it really depends on your skills. Yeah, but if you have any question in the first case, I can help remote review your case, guide you how to place your beam. But from my experience, if you have practiced many times, you can basically make a better plan than hyperarc, to be honest. Hyperarc is basically a fixed beam geometry. It's always the same geometry angle, couch angle. Yeah. But if you have experience, you basically can, use even better geometry, beam geometry, can achieve better plan. But it does require experience. Yeah. Okay, Martin, I saw your hands. Can you hear me? I cannot hear you.
Hello?
Yes.
We hear you.
Yes, I was inquiring. There's an image which you displayed with a patient who has not shaved, and yet in these other normal techniques we encourage for reproducibility. So was this a single session, or it is not necessary in SRBT for a patient to shave?
I'm sorry, can you repeat your question?
In one of the images you displayed,
Yes.
the patient has not shaved off the hair.
Yes.
Was it because it was going to be a single session, or it is not necessary in SRS?
The
For
46 mass,
reproducibility.
the plan with 60 mass. Oh, okay. The question is about whether we should give single fraction or multiple fractions, right?
No, is shaving off the head not necessary?
It is not necessary, no.
Okay.
We've got a couple cases where we had some issue with very a large volume hair, and the mask is not reproducible.
I see.
But that's a case-by-case basis where we can ask the patient to have a different hairstyle. But almost never is it required to cut or shave the hair.
Okay. I think that we are already line 40, and I think it's turned out a very good session, except some technical problems. I will check the video, and if it's two different videos, I will going to combine together and share with everyone. And thank you so much. We'll see you, I think, October 22nd. Yeah, we'll focus on lung and a spine. Okay. Have a good night. A good evening. Bye.
Bye. Have a good day.
Bye-bye.